Good afternoon, everyone. Thank you for joining us for this HCV Action webinar. So my name is Aidan Wylie, and I am part of the Policy and Parliamentary team at the Hepatitis C Trust, and we coordinate HCV Action, which is the network for professionals working in hepatitis C care. So we've organised this webinar to discuss hepatitis C services in Scotland during and beyond the Covid-19 outbreak. So the COVID outbreak has obviously caused significant disruption to health services. So we wanted to bring people together to consider how we can mitigate any impact on progress towards achieving hepatitis C elimination. However, we've also seen, some great innovations in care as a result of the crisis. So we think it's important that these are highlighted and shared as well. So we'll be discussing some of those today too. So we've got four excellent speakers who will be providing updates for us today. So we have Professor John Dillon, who is the clinical lead for bloodborne viruses for NHS Tayside. We have got Wylie, the lead officer for Hepatitis Scotland, Rachel Halford, CEO for the Hepatitis C Trust, and Petra Wright, the Scottish officer for the Hepatitis C Trust. So once we've heard from each of the speakers, we have some time for questions as well. So please do feel free to submit a question at any time during the webinar. If you're watching via Zoom, you can type your question in the Q&A box, and that'll be either at the top or the bottom of your screen, depending on the device that you're using. And if you're watching via YouTube, you can just enter your question in the comment box. If your question is for a specific member of the panel, it would be great if you could state who the question is for. And my colleague Noah will be monitoring these questions, and we'll put some of them to the panel once we've heard from each of the speakers. So with that housekeeping out of the way, let's move on to our speakers. So it's a particularly good time to be hearing from our first speaker. As many of you will have seen the news last week that hepatitis C elimination has been achieved in the Tayside area, which is a fantastic achievement. So I'll now hand over to Professor John Dillon to tell us more. I think you're just on mute at the moment, John.
Thank you. You can hear me now? Good. So I've been asked to talk about the Scottish approach, so how we think about elimination of hepatitis C in a post-COVID world and how we get back to what's called the new normal. And I think it's important to bear in mind that we're not trying to go back to the new normal. We weren't treating enough patients with hepatitis C before, and so we don't want to go back there. We want to go forward. We want to think about where we're going to get to next. And Scotland has definitely committed to elimination by 2024. The Minister has been in the press last week reiterating that point. So we're committed to 2024. Our colleagues across the border in England are committed to 2025. So we need to start talking about elimination. So that's got to be our new normal, and we've got to do that in a COVID positive world. Have the next slide, please. So we need to start thinking about the pathways for diagnosis, treatment and cure. And those should all be one single word, no spaces, no gaps. It's got to be about moving everybody through that process. Dealing with their other issues as well, but from the point of view of hepatitis C, diagnosis and treatment have to be one word. We just move them through, and with successful treatment, we're going to cure. Many of the people that we're trying to reach for hepatitis C cure are coming from many different places. And this schematic just shows you the different pathways that are available in NHS Tayside. I just want to go through them to get you thinking about what the pathways are like, how they're different to what you do, how we should be moving forward, and how they're going to change in a COVID type of world. On the left-hand side of the screen, you can see standard hepatitis C testing and treatment in healthcare facilities, be that hospitals, general practices, when you visit the nurse, etc. That's going to be venous blood, and it's going to lead to a referral into a hospital clinic probably, although that hospital clinic might be outreached and closer to you. And increasingly, we'll be using video technologies like Near Me in the healthcare service to try and improve that pathway. And that's one pathway to think about. It's not enough on its own, and we have to have other pathways to partner with it. It's the backbone of the traditional way that hospitals and general practice do things, but it's got to be more than that. Many of you will be aware of the work we've done in pharmacies, where we've trained pharmacists to do dry blood spot testing for hepatitis C, hepatitis B and HIV. And then either the pharmacists themselves, if they're appropriately trained, can prescribe the hepatitis C therapy and get the patient through therapy. Patients require one set of conventional venipuncture to get a fibrosis measure done, or else they have a nurse or another worker visiting the pharmacy with a portable fibroscan machine to give you that fibrosis measurement. And it's important to realize that doesn't change what we're going to treat people with or change whether they need treatment or not. It simply determines how much follow-up afterwards people are going to need. So it shouldn't be a blockage to getting people onto treatment. And that pharmacist, if they're not appropriately trained or don't have large enough cohorts of patients to make it worth their while, a visiting nurse can come in and treat people on opiate substitution therapy within that pharmacy. Within our drug treatment services, we have all the key workers are trained to do dry blood spot testing, and so they can perform that task with their clients as they come across the door. And we have embedded on-site specialist nurses who can then take over the hepatitis C therapy if they're positive. A similar pattern in prisons, and in needle exchanges as well, we can do the same thing. So that broadens the whole reach. And the key thing is the diagnosis becomes easier and can be done in environments that are familiar to the people who need to be coming across hepatitis C therapy. Can we to the next slide, please? And the key part of this is simple technology. Venipuncture is the common way of getting blood to allow us to do testing for bloodborne viruses, but it requires a person with advanced skills to be able to do the venipuncture. And let's be honest, many of the people affected with hepatitis C have particularly difficult veins, and if they've got a good vein, they're not particularly keen on letting a medical practitioner at that vein. So dry blood spot testing is nice and simple technology, a simple blotting the spot card, a simple stylet stabbing the side of the finger. And while I can't train anyone to get blood out of a stone, I can train everybody to get blood out of a finger, and everybody can therefore do it. Now, this is not a substitute for venipuncture. If you can do venipuncture, do venipuncture. But if you can't do venipuncture, this gives you the option of being able to do the test. Therefore, why limit it to doctors or nurses, which is happening in some health boards? We should be spreading this across everybody that is in contact with people that may be affected with hepatitis C. So clearly many people can access testing through their general practitioners, but many people will be in other environments where they are fearful of going elsewhere, but are comfortable within a needle exchange or within the pharmacy where they pick up their opiate substitution therapy, or in their treatment centre, or in any one of the other sites I've listed on this slide. So in Tayside, we've trained over 250 people to deliver dry blood spot testing from a variety of backgrounds outside the traditional doctor and nursing backgrounds, and they can provide therapy. Have the next slide, please, or the cartoon. And if you can train somebody to do the dry blood spot testing, you can train them to read the results. You can train them to relay the result to the patient. You can train them to refer the patient. And so you take all of those steps out of the process and make it really simple. And that's the beauty of dry blood spot technology. Have the next slide, please. I showed you all of those different pathways, and this slide just shows you the numbers of tests done in each environment and the rate of positivity. So you can see within general practice, large numbers of tests being done over time, and about 3% positivity rate. And within secondary care, hospital practice, there are even more tests being done year on year. 80,000 tests in Tayside, less than 1% of them positive. And in addiction services, a relatively small number of tests, a couple of hundred, but 12% positive. In community pharmacies, 11% positive. Needle exchange provision services, a very high positivity rate, up at 26%, on a very small number of tests, and similarly in prisons. So you could look at this graph and say, oh, we need to move all of our testing out of secondary care and do it all in the prisons. Next slide, please, or in the needle exchanges. But if you actually look at the numbers of tests taken and the numbers of people that are positive, although the percentage positivity rate is low because of the volume of testing, it's still general practice and hospital care that are finding most of those patients. And so I think it's important that they carry on doing what they're doing. But even when there's been huge amounts of testing in secondary care and in primary care over many years, there's still substantial numbers of patients that haven't been found. And when you introduce new pathways of testing within drug treatment services, within community pharmacies, and within needle and exchange provision services, you find new patients. And that's clearly very important. So it illustrates the point that we need lots of different pathways to allow people to access. And as we redesign our services post-COVID, we need to think about that and how we're going to reach them. Now, a lot of these drug treatment services and community pharmacies have high footfall. So in the pre-COVID days, you'd have people coming in every day to pick up their opiate prescription. Now, clearly that has changed radically, and most people are on weekly pickups now, or we're moving towards long-acting buprenorphine-based products where people can be treated monthly or so. And so that footfall is going to change, and we're going to need to redesign the way we offer those services and become much more one-stop shop based rather than having relying on the fact that we're going to have lots of opportunities to contact people. Next slide, please. And it brings us on to then thinking about what we actually need in terms of a treatment pathway. Most of our concepts of treatment pathways were developed when we had interferon-based therapies that we had to deliver in complicated ways because these were dangerous, risky therapies that needed a lot of monitoring, a lot of care. We don't use those drugs anymore. The drugs that we use are extremely safe, extremely simple, and we can dispense with large amounts of the things that we thought we needed. And in fact, the only real test that we need, other than a positive PCR, which we can get our finger spot test, is some estimate of liver damage and fibrosis. And that doesn't determine treatment, as I'd said before. It determines follow-up. It shouldn't stop your entry into treatment. And irrespective of how good or bad your liver is, curing your hepatitis C is going to make your liver better. So if you've got a trade-off between curing the hepatitis C or not finding out about their fibrosis stage, you cure the hepatitis C and we'll worry about the fibrosis later. And that should be our underlying principle. So if we want another new redesign, that's the thing we need to focus on. And finding out about the fibrosis doesn't stop us from starting treatment, and we can then either capture the fibrosis data and statement during treatment or after treatment. Next slide, please. So there's been much talk about hepatitis C elimination and what it is, and so we should think about what our target should be. So most people think of elimination as the reduction of a burden of infectious disease to a level where there is little impact on public health, which is a nice general way of thinking about a good principle. A more rigid dictionary definition would be the reduction to zero of the incidence of infection in a defined geographical area. Now that's purist and very mathematical, but it's almost impossible to prove, and it would then require people never to be allowed back into that area, etc. And so the WHO has come up with this definition that gives us a number to go with the first one of a 90% reduction in prevalence, and that's the working diagnosis that we're working towards in Scotland and England. Normally for most diseases that's achieved by the use of a vaccination. In hepatitis C we still don't have a vaccine, and it's not likely that we're going to have one in the immediate future. So we're aiming to deliver that by treatment and prevention, and both of those are very important. Now, there's a parallel concept around treatment as prevention. It's different from elimination because you can reach elimination, touch it, and then lose it and go back again if you have reinfections or don't treat reinfections and limit it. Treatment as prevention is the idea that by reducing the prevalence amongst people who are capable of passing the virus on, and that in the UK context is predominantly people who inject drugs, should reduce transmission, and so there will be less spread of it, and therefore reduce the need for future treatment, and would be cost saving. This is the subject of another trial in Tayside, and we will answer that question to see whether it works. It doesn't change whether we can reach elimination or not. It just changes how hard you then have to work afterwards to keep the virus eliminated. And it's important to remember the two are separated, so we can get to elimination even without treatment as prevention working. Have the next slide, please. So what does elimination look like, and how close are we in Tayside? So if we take for Scotland that we have a chronic hepatitis C prevalence in the population at the moment of about 0.5%. About 14 years ago, it was about 0.7, and it's fallen for two reasons. People have died and the population have got older, and that's very sad. And also the numbers of people who have moved into injecting drug use has also declined, and the provision of harm reduction measures in terms of needle exchange, etc., have improved. So those factors have brought the prevalence down a little. So if you take that 0.5% of the population and apply it to Tayside, that means there should be about 1,975 people in Tayside that have hepatitis C at the moment. And that means the 90% of that number, the chronic prevalence at 90%, is 1,776. So that's the target, if you like. That's the number we're aiming for. So if we then start to look at our records, we think, wow, we've diagnosed 4,308 patients. The records must be, the prevalence must be wrong. It's all nonsense. And that's true. We have, over the 20 odd years that we've been testing for hepatitis C in Tayside, diagnosed 4,308 people. 980 of them were PCR negative. 694 of them no longer live in Tayside and have moved elsewhere. 664 have moved or have died, which is sad. We haven't got to them in time, or they may have died happily in old age. And that leaves us 1,970 alive and living in Tayside, so well over our 90% that we've already diagnosed. Using those pathways I've described to you already, we've reached over that threshold. Now, clearly the 1,975.5% of the population is roughly an estimate, but it might mean that there are only 5 people left in Tayside that we haven't diagnosed. And if you're one of those 5 and you think you might be at risk, come and see me and we'll organise a test. How many have we now treated? So we have treated and cured 1,813 people in Tayside, which again is over that 90% level. So we have achieved elimination, and it's on that basis that we can claim the elimination claim. Now, the 0.5% of the population might be right or wrong. We can argue about that thing, but that's the evidence that we have, and that's our target. So each health board, each region, each area in Scotland needs to be asking itself that question. What's our target number? What's our 0.5% for our area, our region, our service? How many people have we diagnosed before? How many of them have we still got? And how many of them have we cured? And that's what we need to be doing in the new post-COVID world of hepatitis C. My next slide. Have I got a next slide? Yes, here we go. So what we want to do is to revise and extend our diagnostic pathways. If you weren't already testing an opiate substitution therapy and needle exchange circumstances, you need to be doing that testing now. You're going to need to revisit your partners in those areas and see how they're working in the new post-COVID way with the reduced footfall, and see how you're going to work around them. But you need to be able to do that. You need to not take no for an answer. You need to take, we need to get back into this idea we're going to have to live with COVID for a long time. We need to be testing for hepatitis C as well. We've got to make sure that we've got highly efficient linkage to treatment, so that we make treatment easily available as close as possible to the places where people were diagnosed, but give them the opportunity to move to other venues if that suits them better. Remember that everyone can be treated. Identify your target. Know how many people you have treated and cured in your area, your region, your service. How many of you diagnosed and still to treat? So have that list in front of you as you're seeing people. Is Joe one of the people I need to get in contact with to make sure he gets treated? How many of you still to treat, to diagnose and treat, and to work out from that the numbers that you need to do? And that's what we need to do moving forward. Thank you for listening. I'm happy to take questions at the end after the other speakers. Thank you.
Thanks very much for that, John. That's a very useful update. I'm sure I speak on behalf of everyone who's watching when I say congratulations again on that fantastic achievement in Tayside as well. So next up, I am pleased to introduce Leon Wylie, who, as I mentioned before, is the lead officer of Hepatitis Scotland. So Leon is going to provide us with an update on their work in the past few months, and with a particular focus on how drug services have been impacted during the outbreak. Thanks, Leon.
Okay, thanks. And in the first person, congratulations, John, and all your team at in Tayside, because they've done fantastic work. So, and that's really great work and an example for many people to follow. In a strange way, at Hepatitis Scotland and our wider host organisation, Scottish Drugs Forum, we're actually a little bit prepared for lockdown. I'd actually taken a digital leadership course through the Scottish Council of Voluntary Organisations in 2019. And as an organisation, we moved ourselves onto the cloud, onto Microsoft 365 and Teams in January. So we were kind of there. But next slide, please. But unfortunately, then came the fog. And next slide. We had to start working from home in early March. And as SDF is a membership-based organisation, we've got quite good links to service users. Next slide, please. And through peer researchers and groups such as the Naloxone Peer Distribution Group, the Addiction Workers Training Program and the Hep Scotland volunteers, we received quite a lot of information early on about problems with access to OST, that's opioid substitution therapy, issues with injecting equipment provision, or what we call IEP in Scotland, and also various forms of stigmatising behaviours, stigmatising incidents happening to people. So these were all quite an issue at that time, because we realised that if none of these things, if all of these things kind of stopped, then there was going to be some fairly significant issues following from that. So an activity therefore quickly started was producing guidance on contingency planning. Next slide, please. For people who use drugs and COVID-19, and that was eventually shared with all alcohol and drug partnerships and all the drug services in Scotland, and it was produced by senior staff in Scottish Drugs Forum and other partners, which included the Sexual Health and Bloodborne Virus SHBBV Prevention Leads Group, other close NHS colleagues, and with support from the Scottish Government. It wasn't really meant to replace local contingency planning, but to help meet specific challenging issues that areas were likely to face over those coming months, and in particular the provision of opioid substitution therapy and also IEP provision. An example of its effect was the wholesale adoption and rapid transition to longer takeaway scripts for OST, and basically the replacing in most cases of supervised consumption, and also a rapid change to different ways of injecting equipment distribution. Naloxone distribution was also increased, and that was through a letter of comfort from the Lord Advocate to allow community services to also distribute it rather than just pharmacies and other statutory services. Early in lockdown, staff were also being redeployed from the alcohol and drugs area, and the guidance group met with the Public Health Minister, and that resulted in a national directive keeping staff available for clients. And also an excellent key information thing was we brought together a key informants group of representatives from areas and organisations across Scotland, both statutory and non-statutory, that allowed real-time information and practice to be shared across a group. An example was, for this process today, was being able to quickly ascertain the levels of BBV testing and the difficulty of restarting it across very different locations and rurality. Next slide, please. The SDF webinars, of which Hepatitis Scotland led 3, were based on reacting to current issues in lockdown, and were highlighting services adaptations to difficult times. The HepScot ones were necessarily focused on wider SHBBV issues such as wound care, the drop-off in all BBV testing, it just dropped off a cliff. And for World Hepatitis Day, we looked at prevention and harm reduction, the need for that to stay so that we can follow through with elimination. The positives of the process, next slide please. Through the work of the SHBBV prevention leads, there was a way of getting real-time information about IEP distribution, both nationally and locally, and that was through the Neo Pharmacy system. And a shout out here to Andy McCauley, John Campbell and Jim Shanley, as the work they'd done prior to this allowed us to be aware of the trends straight away. Although the work done through the IEP guidelines, the work done through the IEP guidelines working group and a colleague in SDF, Sophie Given, had already advise partners on alternative ways of IEP distribution, which were then able to be quickly acted on after lockdown. And this included forms of IE distribution that people weren't really that into, but suddenly found a need for. So it was things like postal, peer-based and outreach services. So services have adapted remarkably through need, and it's useful to highlight that oil tankers like the NHS can sometimes turn quite quickly if they feel the need and the necessity. Like in Midlothian, they showed that using assertive outreach in a targeted and appropriate manner, like piggybacking service appointments and as John was talking before about adapting workups towards hepatitis C treatment, gave them the ability to continue Hep C treatments right throughout lockdown. And it was also evidenced in Scotland and in England that giving people who use services greater agency over their treatment with regards to OST has had a positive effect in a large proportion of service users. Some people actually decided to stop their OST and take themselves down without consultation, but they had the ability to and the agency to, while others adapted their doses to their daily needs. And in a way, by being forced to give people autonomy over their treatment, we've got a natural experiment that currently seems to have more positives than negatives as people reduce their risks through choice. Some services have distributed mobile phones to people with no means of communications, and there's been much more positive engagement with services as some of these people are able to engage more on their terms, so they're not booked into a time that they have to be there, and their engagement has increased. There was peer-led research carried out by SDF and also by Hepatitis Scotland after the first period of lockdown, and it looked at how people were using services, and there were many positive reflections on engaging through electronic communication, although providing they had easy access to it. And another useful aspect was a decrease in stigma felt by many as they didn't have to attend pharmacies and other places on a daily basis, and in circumstances where they could be othered. And where homeless people were accommodated in hotels, where there was that quick action to take people off the streets, if services engaged quickly, they had the opportunity to provide a real one-stop shop of services, including testing, wound care, and rapid access to OST. Next slide, please. Unfortunately, it's not all sweetness and light, and there's been evidence significant drop-off in IEP availability. So needles and syringes, they dropped very significantly at the start. They've come back to about 2/3, and that's no matter our efforts to enhance distribution. So with the fall away in BBV testing that also happened, that just fell off a cliff totally, and that went beside it. We don't really know what will happen when we fully emerge, blinking into the light post-COVID. Although social isolation has obviously decreased the amount of risk episodes of people sharing, the opportunity to share, etc., the effective reuse of equipment and the higher risks involved with them, and the lack of access to wounds, inspections, etc., means there may be a fairly significant morbidity and mortality, which we're currently unaware of. When we're looking at and also when you're looking at someone's personal assessment of risk, the bleak dystopia of a pandemic may lead to people taking greater risks, having a more nihilistic kind of approach to their use. And there is some evidence of a higher drug-related death toll this year, and there may also definitely be increased infections. Through recent webinars, next slide please, we've had Magdalena Harris presenting peer-based research regarding harm reduction. The webinar held for World Hepatitis Day was focused on prevention and harm reduction. As John has shown, we have excellent results when we work hard for elimination and to provide all services and to wrap around those services to do that. And treatment as prevention has helped greatly on that. But to maintain elimination, we need to continue to maintain prevention and harm reduction efforts. If you reintroduce a vector, Hep C, back into a pool that's that we've gotten rid of it from, if we're not aware, it can easily get out of control unless you maintain prevention and testing initiatives. An example is the HIV outbreak in Glasgow, where there was a good level of harm reduction, but due to a combination of circumstance and change in drug patterns of use, with cocaine and the purity of cocaine, etc., and taking the eye off the testing ball, we're still dealing with an expensive outbreak in people and monetary terms. Therefore, we need to improve the prevention response. So the last slide, please. Oh, sorry, go back, please. We go back. So the things that COVID has taught us, our strategic work in COVID has shown that SHBBV work should not exist in its own space. It's inextricably linked into the wider field of substance use. For an example, getting a number of services piggybacked during one appointment has worked very well. And when someone comes in, that's the lessening of risk and lessening of exposure. So it's interesting the exposure between the COVID and the aerosol-based stuff and the blood-based things where there's very similar ideas. But there's been better individualized use of OST, and we need to think more about that individualized approach to it. Giving more control over dosage to the service user is likely to limit the times of topping up, because they'll use it when they need it, and sometimes they'll reduce it. More assertive outreach, improving access to services, thinking about communication with service users who are currently less likely to be able to access electronic equipment, etc., and thinking about how we distribute and give them access to communication resources. Looking at stimulant issues in greater depth and re-educating staff about interventions, because as we saw with the HIV outbreak in Glasgow, there was a cocaine use there, which led to a much higher increase in use of needles, number of injections during the day, and increased risk taking as well. So we need to potentially look at medication assisted therapy with stimulants as well, because all of these things kind of combine to when we're looking at reducing SHBBV issues. Evidence put forward by Magdalena Harris shows that best practice is encouraging the user to use in a way which enhances their drug use while staying as safe as possible. And in a kind of a way, it's party hard and stay safe. In addressing what has happened from COVID, we need to think about how we evidence the positives. That's a key thing. We need to evidence what these positives are. I can talk about them, but we need to quickly evidence them, because there's been some significant changes in the way that we deliver services. We need to how to evidence them, how to maintain them, and also how to maintain preventive thinking when public health cuts are continuing. The likelihood of us getting and maintaining elimination of Hep C is going to sink or swim on prevention work. And next slide, just as a little adjunct, that's Lou Reed. I tried to give up drugs by drinking when we've had some stats coming out about the levels of drinking during COVID increasing. Then we need to think about that impact as well. And thank you.
Thanks very much, Leon. That's a very useful overview of the situation in drug services. So just a quick reminder, please do keep sending in your questions. You can do so whether you're watching via Zoom or YouTube. We'll be monitoring both, and we'll put those to the panel once we've heard from all of the speakers. So our final two speakers are from the Hepatitis C Trust. So first of all, we have Rachel Halford, the CEO of the Trust. And Rachel's going to give us an overview of some of the outreach work that's taken place in England and some of the lessons from that which are relevant to work taking place across the UK. And we'll then hear from Petra Wright, who is the Scottish officer for the Trust. And Petra will speak about the situation in Scotland specifically. Rachel.
Thanks, Aidan. First slide, please. And thank you. Congratulations to John. I have to say that incredible Tayside. And Leon, thank you. It was great to hear about the strategy and how together it sounds like it came across Scotland during the COVID crisis. I mean, what I wanted to do, I'm just going to give a really little whistle-top tour around I think really what it was like for us as a charity during COVID. And I think it's really important because I think that it's very easy to forget how difficult it has been for us, we're based in England, and it sounds like from Leon's presentation, there was a lot of joined up working in terms of information sharing. For us at the Trust, we had to we did deliver work, and I'm going to go on and talk about that in a minute. But ahead of us doing that, we actually had to produce our own COVID guidance. We had to do our own COVID plans. And I think that this can't be underestimated, the impact, being a patient organisation, working with people on the ground, what we had to put in place first before we could, well, I mean, I guess, to look after our own staff, but then before we could actually get out and take care and support the patients who were either accessing hepatitis C treatment, or our peers, or people who were just vulnerable on the ground. So we actually put together a COVID plan and guidance, which we are now using. And I'm sure, you know, as none of us really know what's going on, we will go from one to the other. You know, we've got partial opening, full opening, lockdown, and I think we're probably going to go backwards and forwards. Next slide, please. So during lockdown, for us, I think once we had all these, we had ensured our own staff safety, we'd made sure we got all our PPE equipment. Our biggest concern was the patients that we were supporting and the peers that we were supporting. As we went down as we entered lockdown, we had over 2,000 patients who were accessing treatment that we were supporting through our peer programs. So one of the most important things was making sure that they were all okay. You know, lots of telephone contact. We provided, and Liam referred to that, phones being provided. We provided a lot of phones, either to our peers or to patients. We supported our peer volunteers. We have a lot of volunteers that work in the community with us. Most of these are people who are either still using or have just stopped using or are new in recovery. And they had limited resources, you know, and quite often it wasn't just about providing that telephone contact for them or providing them with the telephone. It might have also been about providing them with food parcels. So a lot of our work was around just, I guess, making sure people were okay. We supported clinicians and nurses by delivering medication. A lot of the clinicians and nurses that we work with across the country were I've lost my words now. They were moved to work on COVID, and that meant that patients were being left to, or were required to go into pharmacies and pick up their medication themselves. This was really scary, really concerning for them, putting them right in the middle of COVID hotspots. So what we managed to do was arrange for the pharmacy collection to be done by our peers. And then we started delivering medication. I have to be honest, not many people actually started in the middle of COVID, with the exception of a few examples of best practice, which happens kind of Newcastle way in some of the prisons. I'm going to go on in a minute and talk a little bit more about the outreach, and it's something that I know that happened in Scotland as well. But just before I move on, I wanted to just say that, you know, part of having a larger number of peers is that, you know, and I referred to this just now, we have up to 60 peers. And one of the things was, it was very easy for us as an organisation to look after our staff, to set up Zoom, to do lots of training, to offer additional counselling. But what we managed to do within that was to offer that to our peers as well. So we actually had training days, whole days, which were set up just for the peers. We managed to train peers on Zoom. We managed to offer them training programs. And I think it was just about learning a new way of working, which we will and we are taking forward as we come out of lockdown. Next slide, please. Just really wanted to include this because one of the things that we realised very early on for us, and this was across the UK, that there was a lack of easy, accessible information about the virus. You know, so there were two kind of categories that we did, and what we did was we pulled together 7 steps to prevention. One of them was more generic, and that was for anybody and everybody. But what we realised was that there was nothing in terms of harm reduction and key safer drug use tips. We produced these. We used the same kind of. I'm losing my words this afternoon. I do apologise. Materials that, you know, that we used so that they kind of became cool and accessible, and we disseminated copies and these flyers across the UK. We disseminated them in pharmacies, GPs, anywhere we could really, and actually got some really positive feedback, mostly from pharmacists and people who were using drugs, which was great to realise that it was useful information that was being sent out. Next slide, please. One of the, this is just kind of headlines of the stats of the numbers of people. So during the, I guess, the core lockdown period from the 23rd of March to the 23rd of June, we provided 4,471 interventions. We completed 66 clinic visits. There were 195 treatment starts. A lot of these were people that were on the books that had just been approved for treatment, and we supported them through this, as I said earlier, just by picking up medications and etc. And then there were 519 people that were found as hepatitis C positive. Now, as we all know, during lockdown, there was very little testing. I think that was one of the biggest concerns was, you know, and obviously it wasn't going to happen because all the drug services were shut down. Next slide, please. I'm going to go show you now how this happened. So I think it was Leon who referred to it in his presentation about the homeless people were housed, you know, and that happened across the UK. And what happened very quickly in London was there was this incredible piece of partnership working. And I think for me and for us at the Trust, one of the best things that have come out of COVID, you know, and there are a few positives, but one of the best positives has been the incredible amount of partnership working. You know, the barriers that were dropped because we all, you know, it really was, we all had to work together as partners. And one of the areas was in London, there were over 2,000 people that were put into, homeless people, people who lived on the streets, that were put into hotels or hostels. And very quickly, a group of clinicians, nurses, peers, including the Hepatitis C Trust, got together and mapped out and planned how we could take advantage of this situation and address all the needs and issues that people who were being housed in these hostels had. One of them being their health, and the obvious, the BBB testing. So as we have in the UK, and we've done a few in Scotland too, we did some whole prison, we do a lot of whole prison hits, which is where we go in and test the whole population. And the idea was to use that same model within each of the hotels or hostels. So over the course of just 6 weeks, we managed to test in 46 different hotels. There were 516 people tested. There were 41 positives. 24 of those were antibody positives, RNA positives, and 11 people started treatment on the first day. You know, and these numbers might seem quite small, but this is a really chaotic group who, they're not difficult to find, but they're quite often difficult to engage because of their lifestyles and because actually for them accessing healthcare is really tricky. It was an incredible opportunity. Since then it's been rolled out across the rest of England, and I know that there were it also happened in Edinburgh and it also happened in Glasgow. And this, you know, it's a fantastic opportunity. We know in England now that the funding's been extended so that the cohort that had been put in the hotels are actually there to stay for a little bit longer. It's incredible. I mean, I guess it saddens me as an individual that, you know, when you really need to, you can find housing for homeless people. So it does beg, you know, kind of makes you think, well, why can't that happen on a normal day-to-day basis? But anyway, we can't go there for this. Next slide, please. So moving forward, you know, for us at the Trust, you know, and I think, you know, across, you know, Scotland, across the UK, you know, I would be lying if I was saying that testing wasn't a concern. You know, I think that John's slide, your slides were brilliant. You know, an opportunity that's come out from the, you know, our work during COVID has been, there's a rider remit for peers, and it was really encouraging to see the numbers of people that you had trained to do testing. I think there's a far greater opportunity now for peers to be testing. You know, another concern is a spike in COVID. You know, and will we all get shut down again, or will we be able to manage continuing to work forward? Optimal and equitable needle exchange provision for all. One of the greatest, you know, kind of when we're talking about elimination, we have to have a really robust harm minimisation, harm reduction, and needle exchanges are paramount within this. Opportunities have been amazing. You know, telemedicines, they've been around for years, you know, and they really came into their own during COVID. Far more people will continue to use telemedicine, I'm sure. Virtual clinics, for us as an organisation, virtual training. And as I've just said, the wider remit for peers testing. That really is a whistle-stop tour from me, because what I want to do really is just to hand you over to Petra Wright. So she is, and I want to get it right, she's our senior Scottish officer who is based in Scotland, who can hopefully provide a bit more of perspective of the patients on the ground in Scotland. So thank you for listening to me, and I'm going to hand over to Petra Wright.
Right, I think I've managed to unmute myself, Aidan. Thank you, Rachel. I've really enjoyed everybody's presentations thus far. One thing that struck me from all of them was Scotland is more than just our cities. And while Glasgow and Edinburgh seem to manage to keep some kind of Hep C service going, the smaller health boards, all of the staff were redeployed out of the BBV services, and essentially they just stopped completely. And in my own area here in Forth Valley, they're really just beginning to start to pick things up again. They're having to prioritise about where they go with this, beginning with all those people who post-treatment require the 6-monthly screening. Many of them haven't been screened for well over 6 months now. We're trying to get them back in to start that. Anybody who was almost ready to begin treatment was stopped, so no treatment initiations took place at all. The other area is the 12-week SVR appointments, which didn't happen, so they have to try to get through them, and that's before we start to look for the new cases that we don't know about yet. One of the things that I noticed from John's slides was that for me there was one major partner in that who was missing, and that's our testing labs. I mean, we've been told here in Falkirk, I spoke to the clinic this morning, we have a list of 5 people in growing who have requested a test. Now, Jim and I can quite easily arrange to have their antibody tests done, but we've been told there's no point in doing dry blood spot tests because the labs aren't accepting any dry blood spot tests. I think the bigger boards as well, how they managed to keep going was by using the near patient testing, you know, the Septide machine, you know, getting people tested, then on treatment on the same day, you get your genotype and everything. And much the same way as people are talking now about that's the answer to the COVID. It's the ability to rapidly test and then begin treatment without having to wait for results, because we all know that that's when we lose people. I'd like to see bigger investment in that kind of thing. The near patient testing and the antibody testing as well. I know that some of the drug services up here, I don't know how injecting equipment provision was provided in some of the smaller areas. My own small town in Scotland, we're quite a large population, but the only community pharmacy needle exchange is a Boots, which is a really small shop, 2 people allowed in at a time, and the queue outside stretching right along the streets. So how people that needed access to needles were going to stand for ages in the rain in front of their neighbours and whoever to wait for needles. The other alternative was the fixed site in Falkirk with CGL. Just say that my own town is a 1-hour bus ride away from Falkirk. The needle exchange was open between 12 and 2. Just to mention that the bus services were greatly reduced, if running at all. So how people were to get from the outskirts into the centre to make use of the injection equipment provision, that escaped me as well. I really believe that going forward to reach elimination, we have to have a total rethink about the group of people that we're trying to find. Not all of them are in drug services, not all of them are in treatment services. Jim and I here have actually had a couple of people where we've got to their homes to test them because they cannot be persuaded to access harm reduction services or go for methadone. They don't want it. Most of these people are working. They're not addicts. It would be good if you had to be an addict before you got Hep C, but you don't. The recreational users as well that are out there, they need access to testing as well. And I would like to see more peer work happening in Scotland. It's our community that at risk. I speak from lived experience, if you like. I know I really hate that word. Lived experience of drug use, lived experience of having hepatitis C. It all counts to persuade people. The one thing that I'd like to finish on is that I've actually just lost another very close friend to liver cancer caused by hepatitis C. And I never want people to forget just how deadly hepatitis C can be if you don't catch it early enough. I'll hand back to Aidan now and take any questions.
Thanks, Petra. That's a really important reminder there of what elimination actually means. Okay, I'm going to pass over to my colleague Noah now to pass on a few questions to the panel.
Fab. Yeah, so our first question is, I'll direct it first at John and then come to Petra because I think it might be relevant for you as well. Someone noticed the testing in mosques in Tayside, and just a question about, do you have any detail about how this was arranged? Did you go to a community group, or did NHS staff reach out directly?
Okay. So Dundee has the second largest Pakistani population in Scotland after Glasgow, and Pakistan has a particular problem with hepatitis C related to iatrogenic spread. There are perverse incentives in their healthcare system in Pakistan to inject drugs rather than to give them as tablet form, etc. So there's about the prevalence of hepatitis C is between 3 and 5%, depending which part of Pakistan you're from. Because we had a large Pakistani community and there was concerns within the community about hepatitis C, we approached them. There's a Muslim Council of Dundee that is where the 4 mosques in Dundee come together. We approached them. We had access through some colleagues who work in the hospital and are of Pakistani origin, so we had them supporting us in this application. So we went and talked to the Muslim Council, and the imams of the 4 mosques allowed us to come in and speak to the community between the imam's sermon and prayers on a Friday. We were able to simultaneously translate my chat about hepatitis C into Urdu for the people that were there. We then were invited back to the 4 mosques to provide testing availabilities that was provided by NHS nurses and doctors who volunteered their time for an hour and a half on a Friday afternoon to go and do that testing. Word then spread through the community, so in the coming months we had a big upsurge in testing from people of Pakistani origin within the clinic. So looking at the numbers of people that we have treated of Pakistani origin, we've probably reached the number of people we would expect to be in Tayside of Pakistani origin with hepatitis C. And we also went to the women's groups that are set up, because clearly there's a sex difference in the way that the mosques work. Not all the mosques had women's rooms, etc. So we were aware of that issue and addressed it there as well. That's what we did.
Petra, I know you've been involved in some work with Shabana, our South Asian officer, in other areas. Is there anything you want to add to that?
Yes. We've been contacting the South Asian community on a number of occasions. We began by doing a testing event at the annual Mellis that they have We had a very successful one in Glasgow, offering at that point in time it was the Orosure mouth swab test. So it was great take up of that, and yes, we did find many antibody positives. At that point in time, we could only refer them to their GP to have the follow-up PCR test. There was a lot of organising between ourselves, and at the time it was Joe Schofield in Glasgow, about who did the test, where the test would go, etc., etc. The most recent one that we did was in the Central Mosque in Glasgow. It was a really brilliant day, and that came about because we were approached by a South Asian charity group, and they asked us if we would provide some training to them on hepatitis C. Their intention was that they were going to go out to Pakistan and join the efforts out there and do some testing in the community. So we had a whole day of testing. We had community representatives and representatives from Glasgow. The training went very well. Immediately they produced their own little video about hepatitis C. One of them was a paramedic, so we arranged for him to have further training from NHS Glasgow and actually carrying out GBS testing. I think what we wanted to achieve was to plant a peer within that community as well, as a way of getting over any stigma or anything like that. But they've always been very welcoming. They realise the importance of hepatitis C. Shabana is very good at touching base with them. I've learned a lot of things, like there's a lot of traffic back and forward between the communities here and Pakistan, not just for visiting family, but for having, don't laugh, hair weaving, various other sort of surgical enhancements for the body that are much cheaper, dentists, that sort of thing. They tend to go back to Pakistan to have these done. So they really need to have a lot of awareness about what happens here and what happens in Pakistan, how to keep themselves safe.
Thanks, Petra. We're out of time, so we will just try, if everyone could try and keep their answers quite short, we can get through as many as possible. So the next question, I think Petra actually answered some of this in her presentation, just on sort of testing protocols and how testing is done. What do you think are the best ways we can get through some of the new challenges that COVID has placed to testing? Is it to move towards more point of care, near patient testing, and look for alternatives like that? I don't know, John, do you have any thoughts on that?
I think we need to look at testing in terms of how does it link to treatment. If you are doing the test in an environment where the person is coming to that environment every week, then you don't need a point of care test. And whether you do a dry blood spot test or venipuncture just depends on the local skill set that's available. That's the key thing. If you are truly in a one-stop environment where you are there for a short period of time and you're not going to see that person again, then you have to ask yourself, does that test lead directly to treatment? If not, why are you doing it? And you've then got to create an environment where you can keep someone for 90 minutes while it's done. And the two testing options, be it gene drive or Cepheid, are not, there's a degree of training and quality control that needs to be given, so they're not simple. So it's not like the Orosure swabs where you can get a simple, easy result. So I think there's downsides to both of them. But if you're in an environment where you need a really quick turnaround, so prisons leap to mind, where you've got very short prison sentences, or you've got a visiting worker who can deliver the test and write the prescription, which we're using in some pharmacies, that's where it's in. But it's a mixed economy of the different testing. We're not necessarily, the near patient point of care tests are not the perfect answer to everything. They have their uses, and we should use a mixed economy to get the answer. But the ideal is having treatment and diagnosis at somewhere where the person is routinely going anyway.
Thank you. Does anyone else want to come in on that very quickly?
can I just
Yes, yeah.
say something quickly? Yeah, I'd agree with John on that, though. With the Halford, when they're over in Glasgow, one of the key things about that was not the person who was diagnosed knowing about it, but it was more the staff who were diagnosing it. So they knew on the day, so they were able to put into train follow-ups, etc. And so it was that recency which kind of drove them. So it drove the staff forward to kind of re-engaging the person in the care. But yeah, testing and distributing testing, how we do it is going to change, hopefully dramatically, and being a lot more focused. But it is that link to care, that you can test someone, but if you don't get them when they're engaged and move them and help them move, not move them, but help them move to care, then you're not, you can easily lose people, and especially now.
Thank you. Sorry, go on, Rachel.
Yeah, just to quickly add in there, because I think it's what we found works really well is the use of peers within this. If you are doing testing in a pharmacy, whether you're using a Cepheid or whether you are doing a point of care test and you've got to bring somebody back, if you engage peers or peers engage with the patients, you have far more chance of them coming back and staying engaged on that pathway. And also, just to put it out there, incentives. Incentives work brilliantly. For some of them, the hardest to engage. I mean, it's been quite there's been a lot of bad publicity, but it's actually been really successful over the last few years, giving people incentives to come back for their results, having them linked in with a peer. I just think it's really important that if we're going to talk about testing, that we need to talk, that we include peers and possibly incentives with that.
Thank you. I'm really sorry for everyone who hasn't had their question answered. I'm aware we've still got a few left, so we'll try and get answers from our panel afterwards via writing and send those around with the notes from this meeting. But all that's left for me to do is to thank our panel for coming on. Thank you very much for your time. And thank you, our attendees, for coming along and listening to us. You can, if you stay up to date with everything that we're doing at HCV Action, via our website, www.hcvaction.org.uk, or on Twitter @HCV Action. But yeah, thank you very much for coming. Bye-bye.